Hello, everyone. Good morning. Thank you very much for your availability in order to participate in this event that we're organizing from Pajo with the participation of the Htlv channel. My name is Leandro Sereno. I work for the regional Pajo office in Washington. And I would simply like to get this session going while we wait for other colleagues to connect and participate. I wanted you to know that we have interpretation into English, Spanish, and Portuguese. So please, in order to select the language of your choice, you can go down to the globe, the icon that you have at the bottom of the screen, and you can select interpretation, and then you select the language of your choice. We have the chat. The chat has been activated, and also the Q&A session. So if during the presentations you have any queries, questions, or comments, please use these apps in order to communicate with the speakers. And I would also want to suggest that on the chat, you can also share where you come from. Please let us know if you work for an institution, for the country, and essentially what your activities are and your level of involvement with the response to the Htlv, so that we can have an idea as to who is participating in this session. And now what I'd like to do is to offer a comment in connection with the session. Once again, thank you very much and welcome. And I wanted you to know that this session is to discuss the Htlv response, concentrating on mother-to-child care and prevention of mother-to-child transmission. And this comes from a demand that was identified in the region for a greater promotion to this issue of the Htlv, and a follow-up on an event that we had last year for the promotion of public health policies for Htlv. Then thank you very much, everyone. And in order to begin, I wanted to invite Dr. Massimo Gidinelli. Dr. Massimo is a physician and infectologist, and currently he is the director of the Department of Communicable Diseases and Environmental Health Determinants in the Regional Pajo office in Washington, D.C. Dr. Massimo, please, you have the floor. Yes, thank you very much.
The campaign that we pushed together to promote Htlv and make it become a public health priority. Now we have a number of tools, we have a number of opportunities, there's an ample recognition of the problem, we still have a number of gaps, but from a year back when we met in the Htlv World Day webinar, hosted by the Ministry of Health of Brazil with the usual range of partners in support. Since then, I think I have the feeling that finally the thinking about the opportunities and the way forward has evolved. It is moving. And today's webinar is a testimony to that progress as we move forward with a reflection about the opportunities to include HTLV in the range of topics that are included in the EMTCT Plus, using now a PAHO acronym to indicate the mother and child health platform, where we believe there's a huge opportunity for addressing the mother-to-child transmission dimension of the HTLV infection. This is something that has already been pioneered in a number of countries, and I've seen in the agenda we will be hearing from Brazil about the experience in implementing this EMTCT Plus, including HTLV, into their practices in some of the endemic areas of the country. So I would like to conclude here, congratulating the organizers, welcoming the participants. I see there's a good number of people connected to this session, which is again a documentary to the interest of the matter. And I wish the workshop will help contribute the progress of this public health chapter. Let's give it a push, and I'm sure that with the partnership with the HTLV channel, some of the academic institutions linked to that channel, and the Ministry of Health Brazil, not to mention other countries in the region which are also pioneering the experience in HTLV, like Colombia, Chile, among others. I'm sure that altogether, when in this partnership, we will be able to make fast and additional progress very soon. Thank you very much, and once again, welcome to this webinar.
Muchas gracias, Massimo. Bueno, y también
Thank you very much,
reforzar el
Massimo.
comentario y
And I
agradecer a
also
Máximo
wanted to
también,
thank
porque fue
Massimo
mucho de lo que se está
because
discutiendo el evento
it is
del
a
año
lot of
pasado fue
what is
también
being
resultado de
discussed, and
su
the event last year was
esfuerzo, ¿no?,
also
para
a result
movilizar el
of
tema de
his effort in order
HTLV,
to
para
mobilize
incluir el tema.
this issue of HTLV, to include this issue in the public health agenda in our region. So today's event is a follow-up and a result of this discussion, which started a couple of years ago. And also, this event is not exclusively organized by PAHO. We have the support of a very strong, outspoken partner in the promotion of policies for HTLV, which is the HTLV channel. And I would like to invite Dr. Tatiana Assone, who's a researcher in the medical school at the University of Sao Paulo in Brazil, and also co-founder of the HTLV channel, so that she can address her opening remarks. Tatiana, please, you have the floor.
Thank you. Good morning or good afternoon. Welcome to this workshop. This is a partnership between PAHO and HTLV channel. I would like to, on behalf of Dr. Angelica, Carolina, I would like to say that this is a very important initiative to promote the policies related to HTLV in the Americas and in the world. Our workshop today will be focused on mother-to-child transmission, which is very relevant when fighting this transmission among people. And I'd like to take this opportunity to thank everyone who is here. And I would also like to invite you to the International Symposium on HTLV from in November in Campo Grande, Mato Grosso do Sul state. We will continue discussing these topics here. And I hope that today we can have lessons learned on this topic. Again, thank you. You can participate using the chat.
Thank you very much, Tatiana, and also thank you very much for all your support in the organization of this event and for the promotion in bringing up the issue of HTLV. And now we move on to the first session, we have a block with a sequence of various presentations. So we will have the presentations. We will follow the order. And at the end, we will have a couple of minutes for a Q&A session before we go on to the discussion panel. So if you have any questions, you can already submit these questions over the Q&A and also on the chat. I believe that it is easier on the Q&A because the panelists can see it easier, but you can also use the chat. And as we discussed, the main approach of this meeting is to discuss this interface of Htlv as a part of the elimination of a mother-to-child transmission, a component of a mother-to-child health. We have the characteristics of Htlv, the interventions that exist in order to prevent mother-to-child transmission, and we have a presentation on this platform Htlv Plus, as we call it, which is the initiative for the elimination of mother-to-child transmission that currently looks at the elimination of 4 diseases: HIV, syphilis, hepatitis B, and Chagas. And the idea is to discuss and to identify opportunities on how to take advantage and make the best of the structure that already exists in order to move on with a response to Htlv. So in order to begin this session, it is a pleasure for me to invite Dr. Carolina Rosadas. Dr. Rosadas is a researcher, associate researcher at the Imperial College in London, working on the mother-to-child transmission of Htlv and co-founder of the Htlv channel. Carolina, please.
Thank you very much for this invitation. I thank you for the partnership as well. Can you see my slides? I can see the second slide as well. Are you able to change the view? How about now? Are you still seeing the second one? No, it's working now. I will be talking about transmission and prevention strategies of Htlv mother-to-child transmission. Well, Htlv is a retrovirus. It creates a persistent infection. There are 4 types, but only 1 and 2 were detected in the Americas. Htlv1 is what is usually related to the development of a disease. So we will be discussing type 1 today. There's no vaccine or therapy, so it is very important to avoid new infections. Htlv is sexually transmitted. It can also be transmitted through contact with blood and other infected materials, and from mother to child, especially through breastfeeding. The transmission occurs during the pregnancy as well. It can happen. It's not very frequent. It's about 2.5% of the cases, but the transmission through breastfeeding is more common, and it happens in 20% of the cases that of the children that are breastfed. And what is the prevalence among pregnant women? Most of the countries don't have this information available. Those who do have data for pregnant women show that it can reach 4% in French Guiana, Haiti, Jamaica, and Peru. And what are the risk factors for Htlv1 infection among pregnant women? There are several factors in the literature. Here we'll talk about low income, low educational level, and domestic violence. So women who are victims of domestic violence in Brazil have 2 to 9 more risk of having Htlv. And this vulnerability really does affect women. We can see that Htlv1 prevalence in pregnant women is the inverse of the GDP income, and the more the income is unequal, the more we see a prevalence of Htlv. And what is the impact of this infection? Well, Htlv can cause serious type of leukemia, which you see on the slide. And you can see here the median survival can be less than a year. Htlv also causes inflammatory diseases, which includes Htlv1 associated myelopathy, called HAM. This is a progressive disease, and 50% of the individuals will end up using a wheelchair. It has an important impact on the quality of life. And in Brazil and in England, we can see that 18% of people report that their QOL is worse than death. We also see that 30% of the patients with HTLV in Brazil had minor neurological symptoms. HTLV also causes inflammatory diseases such as infective dermatitis that you can see on the photo, uveitis, pulmonary disease, arthritis, and this list goes on and on. Professor Lloyd has just published recently this high proviral load associated with diabetes and chronic kidney disease. A person with HTLV has risks of other co-infections, and they can also have a severe case of some diseases, and this happens with spondylolisthesis. It can also cause therapeutic failure. The meta-analysis revealed that HTLV is associated to 16 clinical manifestations, and it increases mortality as well among those affected. And moreover, HTLV has a social and economic impact. Many people suffer with stigma, social exclusion. Patients are afraid and they feel guilty for transmitting the infection. This can impact productivity. It can also be associated to early retirement and premature death, and impacts income and daily activities as well. The daily activities might not be a source of income, but they are important for society as well. And the impact is also affecting caregivers and family members. So HTLV, which already affects vulnerable population, ends up contributing to the continuation of the inequities in health. And why the prevention of HTLV from mother-to-child transmission is a priority, because the development during the childhood is related to a higher risk of the disease. So when the infection happens in the childhood, the risk increases to 20%. Infective dermatitis is primarily a pediatric disease, so children have a high risk of developing a neurological disease afterwards. The vertical transmission contributes to familiar aggregation. It's very common for this virus, as we can see here, and this accentuates health inequalities. When we prevent vertical transmission, we interrupt a chain of transmission. And this is important because most diseases associated to HTLV have a long incubation period. If we don't have a screening for the cases, testing pregnant women, for example, the individual will have a late diagnosis and will be transmitting this virus throughout his or her life. And the diagnosis is also an opportunity to identify other individuals. And this kind of work was done in Bahia state in Brazil, and 32% of the family members of pregnant women were HTLV1 positive. So it was a screening opportunity that helped us identify other individuals. And what are the risks for vertical transmission? We have already focused on some, and today I'll talk about duration of breastfeeding because this is associated to prevention strategies. How do we prevent vertical transmission? There's no consensus in terms of strategies during the pregnancy and during delivery. Most interventions try to prevent the transmission during breastfeeding. The most effective strategy nowadays is avoiding breastfeeding and offering formula instead of breast milk. There's also the possibility to pre-stop breast milk or to limit the breastfeeding period. Are these interventions effective? Well, since the 80s, Professor Eno has been talking about the effectiveness of avoiding breastfeeding. And these numbers reach 31% of reduction. And using formula also helps. We can look at the literature and see that the use of the formula avoiding breastfeeding infant is an effective strategy. In Nagasaki, we see that in the 80s, this was implemented and they saw a reduction of 85% in transmission. And there was a reduction from 20 to 2.5% of HTLV transmission, and the prevalence of HTLV among pregnant women was also reduced. We can also think of other strategies, and there was a recent meta-analysis here, and we see that the freeze-thaw milk does not increase transmission risk when compared to the formula, and also breastfeeding up to 3 months. But if this breastfeeding happens until 6 months, the risk increases by a lot. So the restriction in breastfeeding is effective, but it has to stop at 3 months. And some women have difficulty breastfeeding or stopping breastfeeding at that specific point. So we need to work on that. If we have interventions that are effective, why are they not implemented all over the world then? Well, when we suggest policies to prevent vertical transmission, we end up seeing some barriers. So how can we overcome these barriers in order to implement these policies? One barrier is the following. Sometimes the status of HTLV in the region is unknown. One strategy is to analyze, to have a situational diagnosis of the HTLV in each region. We have to identify specialists and community leaders, people living with HTLV so that they can help us in this work. We also need to understand the prevalence and the distribution of HTLV in each region. We can carry out a literature review, or when we don't have information, we can get data on blood donors. And of course, there will be an underestimation of the prevalence here. For the Parro region, we have blood testing. More than 90% of the countries test the blood donated. So this can be used to estimate the number of HTLV cases and vertical transmission. We also need to evaluate the existing policies, not only policies that are specific for HTLV, but also policies that could integrate HTLVs, such as, for example, campaigns on sexually transmitted infections. And then we need to define priorities and strategies. We worked with Dr. Angelica and the ministry team, and we assessed the scenarios, including the public policies in Brazil, and this model can use in other situations as well. Another barrier is the impact of HTLV on health. It is usually considered minimal, and so HTLV is not a priority. I think that today I have shown evidence that the impact is not minimal. What does happen is neglect and an underestimation. So this barrier is related to the next one we're going to see. This is very important. Lack of knowledge among healthcare professionals and community. Dr. George Kassev showed this. A patient said that a doctor asked her what HTLV was, and another doctor said that they didn't know that it could be transmitted from mother to child. This is the situation, and we need to change it. Well, there are some strategies so that we can do this. We need to empower patients so that they can share their experiences and so that we can reach the policy makers and healthcare professionals. We had a meeting in Brazil with people living with HTLV to discuss this topic, and it was a very productive meeting. We can also use social media to spread the information. We do that on HTLV channel, and here is Erica. She is living with HTLV in Brazil, and she shared her experience with thousands of people in Brazil, and it was excellent feedback. Many people had never heard of it, and they thanked her for the opportunity to receive this information. Other strategies are events like this one today or last year's webinar, in which we discussed HTLV and we brought the information to the policy makers, and also including HTLV in the strategic planning for STIs. This should be done by WHO as well. That is very important.
O Brasil tem muitas experiências exitosas também nesse sentido. Outra barreira que a gente encontra é o fato de não ter tratamento para o HTLV. As pessoas acham que não vale a pena testar para o HTLV justamente por não ter tratamento. Importante destacar é que é diferente não ter tratamento curativo de não ter tratamento. A gente tem tratamento para as doenças associadas ao HTLV, a gente inclusive tem guias internacionais de manejo clínico e nacionais, aqui no caso o Guia de Manejo Clínico do Brasil, e o fato da gente não ter tratamento curativo, na verdade, vai reforçar a importância da gente implementar estratégias de prevenção. E isso, na verdade, volta para a nossa barreira de falta de conhecimento sobre o HTLV. Para a gente tentar reverter isso, é importante o desenvolvimento de guias de manejo clínico. Esse é o exemplo do guia feito no Brasil, né? Aqui um fluxograma de acordo com as recomendações do Ministério da Saúde. Recentemente foi publicado uma proposta de manejo clínico de gestante e bebê pelo grupo da Inglaterra, e também tem um guia de manejo clínico publicado pelo Chile. Outra barreira que a gente encontra é em relação ao diagnóstico laboratorial do HTLV. Muitos questionam se esse diagnóstico ele é confiável. O primeiro ponto que é importante destacar é que o diagnóstico ele é baseado num fluxograma, onde a gente tem um teste de triagem seguido de um teste confirmatório. O fluxograma diagnóstico ele não é utilizado só para HTLV, ele é utilizado também.
Program is not only used for HTLV, therefore it is reliable and it is being used in several countries. In order to face this barrier, it's important to take into account diagnostic fluxograms. In clinical management in Brazil, there are two types of fluxograms in order to take into account the different realities that we find in the country. Our group showed that pregnancy does not impact adversely the diagnostic tests. Therefore, the diagnostic test used for the general population can be used in this case too. This is proposed in Japan to test prenatal, and this is the Chilean proposal. Another barrier is the lack of studies for cost effectiveness. This showed that this can be cost effective, including in England, where the prevalence is very low. We have a model to estimate whether the prenatal testing would be cost effective. This will be available, and each community can put in its own information to verify whether it is or not cost effective. In Brazil, we compare the status quo, that is without prenatal testing, without screening, and we used cabergoline as well, and HTLV antenatal screening, and we used QALY, which includes both quality and quantity of life. We calculated the ICER, or ICER, and in Brazil it is it is equivalent of $7,000, which is considered cost effective. There are other different levels that are considered depending on the country. In terms of preventing over 1,000 illnesses per year. We have an IECR of almost $5,000. All tests that we did were cost effective, and all of them were under 2. The factors that are most influential in this model are prevalence of HTLV in pregnant women, the probability of vertical transmission over 6 months of breastfeeding, and the cost of screening tests. The only factor that can be altered takes us to think in terms of screening costs. If we use a test which is more specific, we can reduce the cost in 25%. Other strategies would be to use a pool of samples which would generate a reduction of 75% in cost. There are other alternatives from the point of view of research in terms of cost reduction. We can use all the lab structure which was developed thanks to COVID to have more access for HTLV testing. Another barrier has to do with the concern about the infections which are reduction due to reducing breastfeeding. We have to have alternative methods. And with cabotegravir, we've been having good effectiveness, and it can be used as a strategy in the future. However, now interrupting breastfeeding with seropositive mothers in Japan and in Brazil is what is recommended. To sum up, HTLV has a very important impact on health, and the vertical transmission is done mainly through breastfeeding. The prevention is a priority, and we have interventions today that are effective. However, we need to have strategies to overcome the barriers so as to be able to implement policies to avoid the vertical transmission. In this context, an important strategy is to integrate HTLV in the mother-child healthcare programs, which is what we're going to discuss today. I'm pretty sure that it will be very fruitful. This is a huge group of people who have contributed to the work which I have just presented. And as Tatiana said, we invite you all to the symposium at the end of this year in Brazil. Thank you so much. Thank you, Carolina.
Thank you very much for that presentation. As you know, we are going to have a Q&A session at the end of this discussion. You can also post questions through the Q&A in the chat. So as we continue, we're moving on to the next presentation. Let me just share my screen. Hope you can see the screen. We have it on presentation mode. I am Leandro Sereno, and I work at the headquarters at PAHO in Washington, and I am the focal point for the EMTC T+ initiative. And my presentation today is going to focus on some of the specific concepts relating to the regional approach for the elimination of mother-to-child transmission of HIV, syphilis, as well as hepatitis B and Chagas disease. I want to just help to launch a discussion so that we can really look into how we can take advantage of this platform, focusing on eliminating HTLV. So let me start off the discussion with just some background history relating to the initiative as it's evolved throughout the region. We go back to 1995 with the PAHO resolution on the elimination of congenital syphilis. These were the first resolutions and agreements that were adopted. However, the more specific milestones were really not seen until about 2010, when PAHO established the EMTCT goal for the regional resolutions and elimination of HTLV, mother-to-child transmission. And then we saw PAHO establish the regional EMTCT secretariat and then the RVC in 2014. Cuba in 2015 was the first country to be validated in the world in this regard. And afterwards, 7 additional countries in the Americas also received that classification. So given the successes and the experiences with the implementation process in 2019 and 2018, PAHO with the member countries expanded this framework, now known as the EMTCT plus framework, dealing with infectious diseases, beginning with hepatitis B and congenital diseases. So when we talk about the impacts that we've expected in terms of prenatal care and we're looking at the estimates of the number of expectant mothers and looking at the characteristics of the health systems in the region. We see that the coverage levels are pretty high. If we look at, for example, prenatal care, and we believe that this is a very interesting opportunity in order to expand and facilitate the supply and access to prenatal care and preventive measures covering these areas that are already envisioned within the initiative. So what does this consist of? What does the initiative actually encompass within the regional elimination framework? Here we see a list of the objectives and impact targets. Obviously, the idea is to achieve and sustain elimination of mother-to-child transmission, looking at impact targets, less than 2% of MTCT of HIV. These are, we're looking at low levels of new cases, including Chagas, congenital Chagas. They're low levels that, so we can see that as a result, this is the result of public health policies that have been targeting these diseases. And now if we look at some of the program objectives in the efforts toward elimination of these diseases, looking at the coverage of diagnostic services, as in looking at, for example, coverage with regards to hepatitis B. And another interesting component within the initiative is that the framework provides us with a package of various interventions in order to achieve the elimination and improve, for example, access to health services, the quality of health services, in an effort to eliminate these diseases. We're not going to discuss these in great detail, but this is just looking at how each package is tailored to the specifics of each disease and condition, and also how it's been adjusted as far as the feeding and before the pregnancy, during the pregnancy, and after childbirth, that are more cross-cutting. These are interventions looking at working with the family nucleus of those identified. So this is an interesting content that we could discuss also in the context of HTLV. After the first decade of the implementation of this initiative, starting in 2010, the initiative was responsible for addressing 50,000 new cases of HIV, and we can see that the impact has been significant. There's still a long way to go in terms of dealing with new cases in the region, but I believe that we have seen successes in the implementation process. Now, let's look at the experiences over that time frame in terms of the implementation. What have we achieved? What are some of the milestones achieved during that 10-year time frame in the context of the elimination of these diseases? Well, first of all, the progress, the specific results are more easily observed when you have interprogrammatic coordination and implementation. And when this coordination of implementation efforts are under the leadership of, for example, the maternal care divisions within the Ministry of Health, you have, in other words, commitment, policy commitment at the highest level within the ministry. That's another, those are other formula for success. There, where you have the political commitment at the highest level. And when the commitment is shared by the highest authorities, then you're going to have more effective results. And the component of maternal health, prenatal care is seen as a quality indicator in terms of disease response measures, as well as maternal health measures. So during the 10-year implementation phase, a new structure and platform was established. You have committees, you have the Regional Validation Committee, the technical advisory groups within the Secretariat, and also a series of guiding documents and tools, progress reports, and standards, regional validation methodologies that have also supplemented the efforts underway. Now, of course, we do face challenges within the initiative that we're also going to be focusing on during the next steps of the implementation process. We have the verticality of programs. So EMTCT Plus requires interprogrammatic efforts with a focus on strengthening maternal and child health coordination efforts. We also are working toward, with the support of the member states, to expand access to interventions, prevention interventions, diagnosis, treatment for disease and prenatal care, and also looking at creating functional information systems to capture programmatic objectives. And also we are keeping in mind the need to strengthen the human rights, gender equality, and the perspective of community engagement in these efforts. And as we conclude, I've identified some salient points in the context of HTLV that I believe could be greatly benefited and by experiences, leveraging on these experiences. So again, I need to highlight and stress the importance of developing an integrated approach where we leverage that experience. I think this provides significant benefits, but for this to happen, and many countries have included HTLV as part of this commitment, and we see a significant political commitment by various countries. Now, we're at an interesting point in time because we've seen a renewed interest in HTLV. We see new evidence identifying specific interventions and dealing with HTLV, and we need to leverage this in order to foster greater dialogue between those responsible in terms of policy formulation. We also need to generate a greater awareness regarding the disease itself, generating awareness among the public, in addition to capacity building and training of healthcare workers and communication and advocacy activities for our with our officials. There's still a lot of questions pending in the context of HTLV, and we also need to foster and support research. So we have a diversity of topics here that are significant, and we need to get answers, clear answers to these questions. And we also need to continue to implement our package of interventions in dealing with HTLV mother-to-child transmissions, estimating the budget needs and impacts. Those are some of our priorities, to also clearly define the what our stated goals and objectives are. What are the expected impacts? And what's the information that we still need to get a hold of in order to see how and what is required in the elimination of these diseases? These are questions that need answers to. And then finally, with the support of WHO and PAHO, we need to identify these interventions, review them, and provide recommendations and recommend these to the member states, looking at what is necessary to clearly define these outcomes. And we don't need to wait for we don't need to get all these answers immediately in order to implement the HTLV prevention and elimination measures. But with the information that we have, we need to look at the expected impacts, but I believe that we have at least enough to start with. And as a support for the research that has been underway, let me just remark upon a call to action in the research. Actually, it's a special program for research and training sponsored by the PAHO jointly with UNICEF and UNDP. And in the we include in this measure HTLV. The proposal is available. It will be available in early September, and we will be receiving proposals related to HTLV, but with a focus on innovative models of care and service delivery in maternal and child health, also cost effectiveness studies, as well as evaluations on and optimization of algorithms for diagnosis of HTLV, aimed at reducing the costs of testing. We hope that this will be available by early September. And we also encourage any comments and feedback and just use this email to provide that input. So with that, thank you very much for your attention. Well, just to very quickly move on to the next presentation during this event. We're going to be looking at engagement efforts with the public and with the community overall. So it's a pleasure to invite Emma from Argentina, someone who is a representative of people who have been impacted by HTLV, and she's a very outspoken activist in fostering public policies in Argentina in this area. Ms. Morano, you have the floor, and thank you very much for joining us during this dialogue. Thank you and good morning. HTLV has been affecting my family for more than 200 years, and it's gone through several generations through breastfeeding and breast milk. In two of the northwestern provinces of Argentina, Jujuy and Salta, is where you see it prevalent, but it can spread and it can affect the population in general. We are 10 children born in an area where the virus was not well known at the time. We lived with HTLV. 2 siblings died as a result of leukemia that they contracted in 2002. At that time, I got to know Dr. Viglioni from the School of Medicine in Jujuy. And since then, my life has changed. And after mourning for my siblings, I went through a period of searching for solutions. Those of us that HTLV are hopefully we are not going to develop leukemia or paralysis or other related diseases, but we need to be well familiar with the condition known as, in this case, immunocompromised conditions that could lead to cancer or other diseases. Living with HTLV also has a negative impact on the quality of life, affecting also mental health. We sometimes wake up with anguish, with fear, a great anxiety. And also, we also feel guilt for having transmitted the disease to our children. So with the doctor, we are constantly in contact, and we have virtual meetings with patients and their families in various countries in the hemisphere. And Dr. Viglioni tries to provide scientific information, but some mothers ask, please explain why did one child die and why did others not die, although they had the same virus? What can be done? What efforts can be made to move forward? For me, it's a great sign of relief when I found out that my children were not infected and they were not recipients of this transmission. So we need to look at see how mothers can prevent the transmission of this disease so that we can all have also the appropriate responses that I did not have at the beginning. Looking at the bank of human breast milk, the perspectives are very clear. This is an opportunity in order to address two needs. One, where we appeal to the UN to recognize November 10th as the World HTLV Day. That would help a lot in raising the visibility of this disease. And also, the authorities in my country need to continue to move forward since their major step that was taken in 2005 with regards to blood bank measures, and now a national HTLV health initiative that urgently needs to be implemented. Pregnant mothers and others that need to be tested for HIV and HTLV, these measures must be implemented. We also need to review the banks of mothers' breast milk The objective is to reduce the transmission of HTLV to the next generations and also to be able to get the proper responses. I want to thank Dr. Mirna Viglioni and Carolina Vivier and Pablo Venecia of the HTLV group, as well as all of the medical staff that are working to make sure that this elimination becomes a reality. I'd like to also thank Mariana Martin, Fabiola Martin, and others from the International of Retrovirology, and to Carol in Brazil, Juan Pablo Rojas, a pediatrician working in Colombia with HTLV, and Ms. Andasuria, someone who is living with HTLV, with vertical transmission. Also to Valeria Roman, Cristina Tomari, for their help, constant help in raising the visibility of HTLV. And I'd like to thank all of the organizers of this event, and Leandro for also raising the visibility of this condition. Thank you.
Thank you very much, Emma, for your participation, for your intervention, and to remind us all on what the purpose is, what the objective is, why we're promoting this discussion, and what we want to achieve with this initiative and with the HTLV policies. Thank you very much for being available today and for participating. Now, we continue with the next item on the agenda, and it is a pleasure for me to invite Dr. Angelica Espinosa Miranda. Dr. Angelica is a physician coordinator of surveillance of sexually transmitted infections in Brazil, the Ministry of Health, and Dr. Miranda will introduce recent advances in Brazil in the development of a public policy for the elimination of mother-to-child transmission of HTLV. Dr. Angelica, you have the floor.
No te escuchamos, doctora. No te escucho.
Então, agora?
Ahora sí, sí.
Talvez eu não sei, vamos tentar ver se vocês
Let's
conseguem
try.
escutar bem.
Let's see
Quero
if you
agradecer
can
o convite
hear
ao
me.
Leandro, HTLV
I'd like to thank
e
Leandro.
falar
I'd
que
like
foi
to
muito
thank
importante
the
agora essa
invitation.
fala da Emma. Te
And it
agradeço
was
muito, Emma,
very
por essa sua
important to
fala, porque
listen
como
to
o Leandro
Emma now.
disse,
Thank you very
por
much,
isso que
Emma.
nós estamos aqui, né?
This
Porque
is why
todas
we're
essas
here.
ações, elas são
All
muito
these
importantes para que a gente
initiatives are
consiga
very important so
oferecer
that
uma melhor
we
assistência,
can
isso para vocês.
assist people.
Falando em HTLV, a gente sabe que é uma infecção de...
We know HTLV has global impact and that it is sometimes invisible among the population and health care professionals. So it's very important to have meetings like these because we need to discuss so that we can offer better services, better prevention, and also help people have a better quality of life. This was published in the Rosada's article in 2019. And here we can see the lack of data. We have few data, as Carolina mentioned. And it's difficult to know the real impact in the world and in our region specifically. Here we see data from studies in Brazil. HTLV is not a mandatory notification disease. So the data we have now come from papers that were published, and we can notice that there are several states in the country that have some gaps. These states have no data. What we can see in the papers is that the northeastern region, especially the state of Bahia, has the greatest number of cases that were identified in the country. The Ministry of Health, through a funding program called ProAdSUS, is financing, along with Moinhos de Vento Hospital, which is an organizing center, and where Dr. Eliana works. They are organizing a national prevalence study so that we can really know what this impact is. We need to know where it is more frequent and how we can control this infection. I have a timeline here with public policies for HTLV in Brazil. We can see that many things were done, but we still have a long road ahead of us. It all started in 1993. Here we had the first ministerial decree in order to test blood donors and related products. And then we developed a guide in 2003. In 2009, there was a decree that established the detection of HTLV in donors of tissues and cell products. Then there was an order to monitor the neonates. In 2019, then, there was one of the most important initiatives for HTLV, which was the creation of the STI General Coordination, and HTLV infection was included there. This problem used to be part of another department that dealt with HIV and also Hansen's disease and others, but there was no specific concern about it. When it was included in this coordination, all the policies and funding systems now include HTLV. And then 2 months ago, we published this ministerial order creating a network for MTCT, replacing the previous system. There was an important change here, which was including the recommendation for HTLV exams during prenatal examinations. This was already done by the clinical protocols. It was part of guidance. We have these 2 protocols here. And here we also talk about avoiding breastfeeding in the case of mothers that are living with HTLV 1 and 2. And we also mention the formulas to substitute the mother's milk, and this is offered by the government. In Brazil, every time we include something in the health system, because it is a universal health system, it has to go through a committee for new technologies. So in our vertical transmission protocol, we mentioned the breast milk avoidance and also the use of medication before, or cabergoline before delivery. And this is important so that people can benefit from these suggestions, which are all suggested and offered by the Ministry of Health. So this new decree recommended screening in the prenatal care. And then we started following these pregnant women and the ones that are seropositive, and then we can observe transmission during delivery. And this is part of this guide, which is for clinical management of HTLV in Brazil. This is the 3rd edition. This will be sent to the commission. It was already sent actually to the New Technologies Committee so that this can be included in the Brazilian health system. Every time there is a ministerial decree, it could be changed later, but when the testing is included by CONITEC and it is included in the healthcare system, it becomes a law, a right. So we decided not to include everything at once for inclusion in the health system because this has a budgetary impact. And if there is no budget, sometimes initiatives might be denied. So we started with a strategy, which was to publish a first technical note considering care and prevention of the MTCT and mentioning the diagnosis and avoiding breast milk and the use of formula. So we're trying to summarize here. These public policies are here. We have many, but still a long road ahead. What do we have today in the country? When it comes to vertical transmission, we have recommendation of exams, prenatal exams. We also have a recommendation so that seropositive mothers avoid breastfeeding, and we offer formula and garbigoline. And there is also a guide for STIs and also a guide for vertical transmission diseases. And there are also specific protocols. Now we already have the 3rd edition of clinical management. We're also working with funding for HTLV research. Every time we have a request for initiatives, we have the consideration for HTLV. We have call for research, and that is broadcast among the society as well, so that research institute and civil society might know about it. We have also included HTLV in campaigns for the general population and for healthcare workers. This was done in 2019 and 2021. It was very important. This year, we haven't carried out this campaign yet because many healthcare workers contacted the ministry in order to know more about HTLV. So we can see that there is more visibility now, and it's very important to do this. So we also have the course, an online course for clinical management of STIs in the America. This was also very important and was done with the PAHO office in Brazil. This is a free course. It is available in Portuguese, English, and Spanish. This is how we can try to work within a network in our region. And what needs to be done? We still need to implement the national testing program in prenatal care. The frequency of HTLV is not uniform all over the country. So this program will probably be implemented in states and areas that have a greater prevalence. In the states where HTLV is not a public health problem, these states can discuss what to do with the Ministry of Health individually. So we have 210 million inhabitants in Brazil, so we can think of how difficult this implementation is and how expensive. Everything needs to be very well organized. We have been working with the civil society and with research groups too, so that we can offer guidance to pregnant women and that are seropositive for HTLV. And we also have to offer tests for the family members and for newborns. Our greatest challenge is notifying, creating a mandatory notification for HTLV in Brazil. We still need to work on this. It still is not a mandatory notification disease, so we don't know the real problem yet. And we need to also work with people living with HTLV in Brazil and with the reference centers. Many of these centers work with HIV. And this week we received funding to work with PAHO Brazil to organize a new meeting. The HTLV channel was trying to do this. We got the financing and now we will be able to organize a meeting for the country. It'll probably happen in the end of October. You are all invited, because it's important to broaden this discussion. We need to include HTLV in the agendas. We also need to advise people living with HTLV and include the confirmation exams as routine in the health system. Here are some examples of courses. We have the STI in the Americas. It's on the platform. We also worked with other groups to organize webinars, and we had a session on HTLV. We have here the clinical management flow. We have one flow for HTLV, but also another one for vertical transmission, and we included a slide about HTLV in that case. We also published here a document. It was published by the ministry, and some articles from this material was published in 2 publications in Portuguese and Spanish, but also in English in one case. So they are all available and free. That was it. I am still going to stay here so that we can then debate the presentations. I thank you again for the invitation. And I also thank you for the interpretation into Portuguese. It's very good to be able to speak my own language. Thank you very much for your participation.
Thank you very much. Now we had reserved 10 minutes for Q&A, but because of the time, and we just have very few questions that were submitted, I believe that we can move on to the panel. The panelists are also ready to discuss this, and we can discuss some of the questions that have already been submitted. But before that, I do want to make a comment in connection with a question that was included in the Q&A, which is precisely the following. Are you considering to include the lab for HTLV in the pregnancy routine lab test and studies? This is the intention. That is the objective for this discussion, to include HTLV with this initiative of EMTCT plus within the framework of these diseases. We recommend that the screening be done with HIV, syphilis, Chagas, and TB. And once we include this EMTCT, it will become a formal recommendation. What we still have pending to make the recommendation, the countries are motivated to do that. Currently, we're motivating countries to do that because this is available. And with the positive result, we can implement this additional testing and screening in order to avoid transmission, EMTCT. But we have a couple of questions before that do call for a response. And the first one would be an algorithm, a specific algorithm, as simple as possible for the diagnosis of HTLV. If only screening is necessary, whether we need a confirmation by diagnosis, what tests are used for the screening, the confirmation. So this is a part of the discussion that we need to have. We need some answers to these questions, and we hope that research will be able to clarify these. And also, what is the most cost-effective model for this implementation? Mainly something that the countries that will be implementing should become acquainted with this, and that they feel involved and interested in implementing this, because this will represent a cost that would have to be reflected in their national program. So we have to define the best information package, the best way, the most cost-effective model to recommend. But we get this discussion going. We're still awaiting some answers, but the objective, the purpose of what we're expecting with the intent that we have is to move forward along these lines. And then we move on to the panel. If you have any additional questions, please use the chat so that the panelists can also address your questions. And for that, I invite Tatiana Assoni. Tatiana is a researcher from the medical school, the University of Sao Paulo, and co-founder of the HTLV channel that we're supporting today. And I would also like to invite Dr. Hortensia Peralta, who's the regional advisor for prevention of HIV and sexually transmitted diseases in the regional office of PAHO in Washington. Thank you very much to you for being available to participate, and I give the floor to Tatiana. Please, Tatiana.
Thank you, Leandro. I would like to invite Professor Angelica too, so she can continue the discussion with us, and Dr. Carolina Rosadas, so that she can be here with us, as well as Dr. Jorge Valdebenito. He is a nurse, has a Master's of Science in Nursing, and works with HTLV and Chagas disease, disease preventions, and he works in the Public Health Secretariat of the Chilean Ministry of Health. And I invite Dr. Diana Librato. She specializes in biochemistry and biology. She's from the Javeriana University, and she works with blood-borne diseases. And she offers support and for the EMTCT Plus initiative in Colombia. So now Dr. Hortensia will begin the discussion.
Thank you very much, Tatiana, and welcome to our panelists today. We wanted to thank you for the opportunity for allowing us to participate in this webinar and to begin with the questions that we have, and also to ask our participants to include their questions on the presentations and on this panel in the chat. Questions to Colombia as well as to Chile. You will decide who answers first. Can you summarize what has been the national response to HTLV and what policies are being implemented in your countries for controlled diagnosis of HTLV in your country, considering the different scenarios, for example, blood donors, milk banks, sexually transmitted infections, STIs, whether there are any guidelines and whether you're following certain implementation guidelines. Thank you, please. Should I start? Should I go first? Yes, Colombia and then followed by Chile. Good morning, everyone. Thank you for giving us this opportunity of participating here today and being able to join all these actions taken on this virus. In Colombia since 2014, we've implemented in blood banks this screening, Resolution 437, going back to 2014. And therein, we established that the mandatory use of a screening of antibodies against the virus, against HTLV, for all blood donors. In the past, this was done by these blood banks in the regions where we knew that, in fact, the virus was present. And we also have another mandate for blood banks where we have a confirmation screening in blood banks. In Colombia, for organ donors, we have a decree 2493 going back to 2004, where we also dictate that they must have antibody tests for those donors. As to the rest, this year, we have been working, and we were able to include in the new policy the new Public Plan 2022-2031, and thus to be able to show HTLV as a priority event And so we kept a goal that was included there, but everything related to blood banks, where we hope to be able to channel more or less 70%, and if we have more, so much better, but to include those persons that have been confirmed by blood banks and to send them to the relative care units, because these donors are staying with us. So in Colombia, we have this already established, and we're also working in developing guidelines for clinical care with a group of experts at a national level, and also looking for the support from countries that have already been working, as is the case of Peru and also Brazil. Thank you very much, Diana. And next, our colleague from Chile. Yes, hello, good afternoon. Thank you very much for the invitation. I am very happy to participate in this meeting organized by you. I believe that it was quite necessary. We believe that Htlv is a neglected disease, not very well studied, with bad academic training. And that is why we're happy to see that we're getting to know each other and that we can move forward in dealing with this pathology. In Chile, regarding Htlv, we've faced some difficulties. In spite of it, we've continued to work on this, and since 2008, Chile has implemented a national blood policy where they include microbiological screening of microorganisms, including Htlv. Also in 2015, we included a technical provision for organ donors, also screening for this disease. Regarding mother-to-child transmission, unfortunately, Htlv is not included in the EMTCT+, but we have a national protocol where we include suspension of breastfeeding and access in the last couple of years to formula for newborns. The lab diagnosis of Htlv is concentrated on the National Reference Lab, which is at the National Institute, Public Health Institute, where we confirm the diagnosis from all the labs in the country. Htlv, unfortunately, is not of a mandatory reporting in our country, but it is a mandatory for the lab. Until recently, and we're projecting to create a committee, a surveillance and development of protocols, mother-to-child transmission protocols. And this year or next year, this will be created as an initiative because we believe that it is essential to have a prevention, particularly elimination of mother-to-child transmission. Thank you.
Thank you. Now, Dr. Angelica, I would like to comment on something before the question. Brazil has been advancing a lot in work related to MTCT, and the ministry will now have to implement and effectively these recommended policies in the context of the health system, and we'll have to offer medical services. So I would like you to talk a little bit about how your department and the ministry has been working with these strategic issues and how you're preparing for this future. Tatiana, this is our greatest challenge. This whole process, which was publishing this decree, then an approval by the technical committee, CONITEC, that approval should happen in September or October, and then this will become a permanent measure. These are all political issues that have to be dealt with by the Ministry of Health, but the implementation also needs a different articulation with states and municipalities, because the states are the ones who will be paying the bill. So how can we convince the states? And this is why it's so important to work in a network We work with the 3 levels of government, and we work with civil society and also with the research groups, because in Brazil we have 3 million pregnant women per year as an average. So we have 3 million tests, screening tests that we have to offer. This won't be uniform all over the country because we have states that have more cases and we have states that have already implemented this, and this helps a lot. Because even before this decree, this national decree, we already had Brazilian states that had their own decrees and that were recommending testing during the prenatal care. So now we have to make this problem visible. We have to show how important it is to test people, and so that this infection isn't invisible anymore. It has to be in the agenda. You mentioned in the beginning that HTLV was added as a priority in many documents published by WHO, and this was very important for the countries, and in our case, it really was. And now we cannot rest. We have to continue our fight, continue our work with the states, municipalities, civil society, and why not involving the universities as well, so that the medical students and other health professions can learn early on what HTLV is. We have to work with the Ministry of Health and Ministry of Education so that this can be part of the curriculum.
Thank you very much. Dr. Hortensia, please.
Thank you very much for these responses. So in this case, we'd also like to ask Colombia and Chile if you have considered, or what are your perspectives regarding HTLV policies? Do you see any opportunities for expanding childcare efforts, prenatal care, and maternal care in order to also expand in the HTLV services arena? Let me just comment that we believe that it's essential that HTLV be incorporated into the MV Plus framework. Chile is making major progress in achieving the major goals and targets for elimination of this, but we need the support, especially in terms of mother-to-child transmission. But we need external support in raising the awareness about having this disease as mandatory notification, part of that criteria, which in Chile is not the case. We need to develop a national public health policy initiative. And in order to close that gap at the national level, we may, over time, develop more long-term policies so that we can make more meaningful decisions in public health. Thank you very much, Jorge. What about Colombia? Well, in the case of Colombia, the fact is that we are aware of the importance of implementing preventive measures for this virus. There is no effective treatment for people that have this virus. In fact, that has been one of the barriers impeding placing this as a major public health that would require regular surveillance activities, because the government would ask, well, why are we doing that and what are we going to provide? So within the policies that we are crafting, we're including guidelines for clinical follow-up as well as surveillance on HTLV and related diseases. This is a priority so that physicians and our healthcare professionals know exactly what to do, because we know that there's still a gap in terms of knowledge. And of course, this is ongoing with the support of PAHO, and they've always supported us in that. They listen to us. And at the same time, we currently are crafting these guidelines, and we're also placing emphasis on the expectant mothers and potentially exposed children in this area. We know that we have to implement actions in order to address the mother to child transmission. That's a top priority. We've addressed it from the very beginning, and we're working towards that end. We also hope to conduct a cost effectiveness analysis of screening in Colombia, because we're aware that everything has a cost involved. So we're looking to see exactly what can be done with the support of WHO and to conduct these cost effectiveness analyses. We would like to rely on the experience and the background of PAHO with regards to HTLV. And within the public health plans, we hope to be able to screen these people and have them included as part of our national healthcare efforts. And also looking at the bloodlines, and also have, well, I think this is an excellent opportunity to capture women in fertility age ranges. And at the same time, we can clearly articulate this information of the both men and women donors, those who are in the fertile age of fertility. And we know that this is important in the preventive and follow-up measures. And we hope in the future we will include all of this within the public health priorities and requirements. Thank you very much. Just to follow up as we conclude this segment in terms of inclusion of programs, what are the two major barriers that you face in the inclusion of these programs within the maternal health guidelines? Well, there's several barriers, in fact, starting with communication issues, as well as in training of professionals. There's also barriers relating to costs associated in launching a national screening program for prenatal care, expectant mothers. Fortunately, as I said at the outset, Chile is making quite a bit of progress in MD+, and where the implementation of screening in both these groups has been very positive. We have a large-scale maternal child care program. It's also necessary that we have clinical and preventive measures that are effective. As Diana already said, sometimes even if we're able to provide diagnosis, we don't have the clinical tools that are necessary to follow up. Access to supplemental food and nourishment for newborns, in providing information to the community. We need to be able to provide the public with information as to how they can recognize signs of mother-to-child HTLV transmission. And also, I think research, epidemiological and clinical research, needs to be supported so that this can lead to developing clear guidelines in dealing with this disease. Colombia's sound is very low. In the case of HTLV, mother-to-child transmission, we need more follow-up. And another barrier that we have has to do with cost effectiveness analysis. We look at, for example, resolution 280 for 2018 that has the prenatal and maternal health roadmap, which didn't include screening for HTLV. And I think this needs to be included. And it must be firmly supported. And MTSCT Plus is now being clearly supported with a well-trained team. And this was within the framework of the prenatal and maternal health roadmap that we talked about. So in order to include that, we need to have evidence that, and we need your support from WHO and PAHO to be able to raise its visibility in the international agenda, and at the same time provide the support that countries so much need. So what are the guidelines? We need to include within the ME Plus strategy and the maternal prenatal roadmap. So this is important because any event that can be added to for screening, as women, for example, age of fertility age, that's going to lead to costs in the healthcare system. And that's where we see some of the barriers. Go ahead, Tatiana.
Now we don't have much time.
When
Therefore, Carolina is answering the questions here in the chat. So if you have any other questions, use the chat. Carolina is answering. Brazil is being an example of the response to HTLV to the rest of the world. Considering the successful experience, does Brazil has a plan of sharing this with other countries in terms of training, a meeting, so that this is disseminated and continues to be? You are doing this to begin with. This event that you also organized, as well as last year's, are important. As far as the government is concerned, we have been working with PAHO in the Brazil office because we are the only Portuguese-speaking country in the Americas. This is a difficulty. Our work with PAHO Brazil, which helped with translation to English and Spanish, with the course, with subtitles in English and Spanish. We have been encouraging this type of action. This moment that you are creating now involves countries, the science sector, civil society, and Leandro mentioned hepatitis, HIV, syphilis. We all have to work jointly to discuss pluses and minuses in terms of difficulties in the countries, because the region has so many of these in common. In Mercosur, we've been working jointly in terms of mother-to-child transmission. In our meeting, we've also discussed this, although our bigger discussion has been making syphilis and HIV visible. We need to broaden this to know what's going on in Chile and Colombia as far as challenges go. we have many problems in spite of the success. And there are actions in other Latin American countries that can help us. Therefore, these exchange moments in presence as much as possible, the International Symposium in the city of Campo Grande, we should include more Latin American countries to talk about their challenges and their proposals. As I said before, the event in partnership at the HQ of PAHO Brazil is important to gather more countries in order to share difficulties in terms of assisting patients with HTLV. This has not been solved here. We'll be discussing with the academia, with civil society, and with the government. Financing is a big barrier. We want to make this feasible. Therefore, we have to gather everybody in order to discuss this. I haven't even discussed with Dr. Socorro and Dr. Aragon. Dr. Rubens is here. You could work towards this meeting of the region of the Americas, because we have the same problems, surely. True, you're right. Yeah, our problems are very similar. We may be at different stages of implementation, but I believe that this is a challenge through which some have already gone, some will go through them, but this is a very valid experience. I'd like to thank everyone, and I apologize because our time is over. I'd like to thank Jorge, Diana, Dr. Angelica, Carol, Dr. Ruben, who joined us, and I'd like to invite Leandro to take the floor in order to conclude the session. Thank you. Thank you very much.
Thank you very much, Tatiana and Hortensia, for having helped to co-host this event. All our panelists, we're also very appreciative. I think it's been a very successful discussion as we became more aware of the progress being made by countries in addressing their responses to HTLV, looking for new opportunities for fostering greater cooperation between countries. We know that there exist diverse opportunities and that we can leverage. And at the same time, we would like to offer the resources of the Pan American Health Organization in supporting these measures, that working in unison with the academic community, the public at large, as we address HTLV. But before I conclude, would like to ask if there are any final thoughts or any final comments from Jorge. Well, no, just thank you very much for this kind invitation, and we are eagerly awaiting to be able to participate in future events such as this. I'd like to thank the Minister of Health so that we can continue as we implement this program. Thank you, Leandro, and I'd like to thank all of our colleagues from the various countries represented here. Thank you. Anything else, Diana? Thank you for kindly inviting me to join this as well from Colombia. I'd like to echo what my colleague said. This closer cooperation, as well as the support provided by PAHO and WHO, working with the ministers, and as we move forward with our own initiatives here in country, again, we have encountered barriers, and to have you as our supporters and allies is greatly needed. And we hope to be able to meet with you directly during the symposium, So looking at the feedback and experiences from other countries, that has also been helpful, working with Chile and Brazil, who are supporting us with their experiences. And Colombia has also received support from Peru. It's all been very significant input, because we don't want to just move blindly. We want to work with guidance of your experience. And Colombia always is welcoming you with open arms. Well, thank you, and we will continue in contact. I now invite Dr. Ruben, who is director of the HIV, hepatitis, and tuberculosis section here at PAHO headquarters in Washington. Dr. Ruben, you have the floor as you can provide our closing remarks. Well, thank you, Leandro. I'd like to thank all of the presenters for the excellent presentations. I thought Dr. Rosada offered a very interesting initial presentation, who reflected optimism about the diverse possibilities of reducing the costs of diagnostic studies through the use of various techniques and measures, so that we can get a better appreciation of the epidemiological situation in each country. It's obvious that all of the economic studies, the implementation cost studies are also very important. I thought I understood, because I was listening to the Portuguese, I thought that there were some therapeutic possibilities with regards to Prevalence, and also Leandro's presentation that discusses the interventions, the holistic and comprehensive interventions in preventing mother-to-child transmission of HTLV, what needs to be done there, and to the extent that political decisions are moving forward in addressing mother-to-child transmission of HTLV, looking at prenatal care, also maternal care, in order to prevent HTLV transmission. And I know that discussion focused on giving a human face to HTLV. And in the case from Argentina, the discussion focused on a family that had it for 200 years, and how siblings passed away in Jujuy. And we also had another interesting discussion about the steps to follow in Chile and Colombia, the next steps. And I agree with the speakers that there are many similar challenges. The good of all of this is, as Leandro indicated, mother-to-child transmission of HTLV requires a lot of commitment. And Dr. Espinoso, I know she's part of the regional committee that focuses on elimination of mother-to-child transmission of HTLV. So I think the approach, the most inclusive approach of HTLV, to make it as preventable as possible in the mother-to-child transmission context. And Brazil, I think, has shared some of the measures that are being implemented, including the breastfeeding aspect. And I think it's important for us that concrete decisions be made. And we need those champions. I think Brazil is going to fit that bill. And we see activities in Campo Grande, as well as at PAHO headquarters in Brazil. We need to closely follow events and see if some of the discussions with the within the PAHO authorities, we'll see what initiatives can be followed up and implemented. We know that within PAHO, there's a great deal of interest in HTLV, and I invite Leandro to continue hosting these discussion forums so that we can develop the next steps that we should follow. So I want to thank you all and wish you a wonderful afternoon. Thank you, Dr. Ruben Majorga. And I'd like to thank everyone else as well for having shared these updates as well as activities that have been implemented in the HTLV arena. So I wish you all a wonderful weekend.